behalf of the Midwestern Vascular Surgical Society, we welcome all of you, ladies and gentlemen, to this webinar. First of all, we would like to thank our sponsor, Gore, who is sponsoring this session. I think it will be a very exciting discussion with 4 very distinct presenters. And on behalf of my co-moderator, Dr. Peter Rossi, we'll get started. I am Bernardo Mendes. I'm a vascular surgeon here at Mayo Clinic. The webinar is we're going to present the 4 talks. They're going to be approximately 10 minutes each of them, and then we're going to have time to do discussions and answer questions and discussion among the presenters and speakers and moderators at the end. If you have questions, you can send the questions through the chat during the talks, and then we are going to go over the questions at the end. You can also send the questions at the end. Ideally, if you have a question that is specifically to one of the speakers, please say so on your message on the chat. But if it is more of a general question, then you don't need to specify. But with that, without further ado, I'm going to give the word to Dr. Peter Rossi, my co-moderator, to announce our first speaker. Dr. Rossi.
Thanks, Bernardo, and thanks to Midwest Vascular and the New Horizons Committee for putting this on. It's my pleasure to introduce our first speaker tonight, Kyla Bennett. Dr. Bennett is an associate professor of surgery at the University of Wisconsin in Madison, appropriately academically pedigreed, got her bachelor's at Hopkins, and then did her medical school and surgical training at Duke. And she'll be talking to us tonight about strategies for percutaneous treatment of zone 2 aortic disease. Kyla, take it away. Looking forward to it. And Kyla, you're still muted right now.
Perfect. That was my plan. Am I showing the presentation screen or the one with all the slides?
You're on the one with all the slides right now.
Oh, also perfect. Okay. Any better? Same one.
No, you got it.
Perfect. Oh, wonderful. Okay. I want to thank the Midwestern Vascular Society as well as the New Horizons Committee for allowing me to talk today. My topic is strategies for the percutaneous treatment of zone 2 aortic disease. I divided this into a couple of groups, the DIY group where you kind of build it yourself, the off-the-shelf available grafts, and one custom pre-order that I'll just touch on briefly. The DIY options are kind of you build it. The advantages are that it's immediately available because you can just use what's already on the shelf for other more standard types of cases. There's some limited case series and cohort studies supporting favorable outcomes, but that brings us to the disadvantage, which is that there's really a lack of randomized trials or even registry data to support or help guide your decision making. So there's a ton of DIY options, so I just touched on a few of them. A couple of parallel stent graft techniques I'll talk about are chimney and periscope sandwich. There are certainly more. Back table fenestration or scallop creation, basically physician modified grafts. And then there's the group that's in situ fenestrations, of which I'll talk more specifically about laser fenestration. For chimney techniques, this is defined as deploying a stent or stent graft into an aortic branch with the proximal portion parallel to the main aortic prosthesis between the stent graft and the native wall. And this extends proximally to allow perfusion of that branch. And you can see that here, the parallel graft, and there's some sizing requirements that go with this. Which brings us to sort of some rules of thumb for this. The sizing formula, which makes you feel like you're sizing appropriately, is you want your endograft for the main aorta at the area of your chimney graft to be at least as big as the square root of 1.44 times the native aorta radius squared minus the square of the branch graft that you obviously size based on the size of your subclavian. They also recommend a pretty long overlap between the aortic graft and the chimney, and that's designed to try to decrease your gutter leaks. So how do you perform this? You do need brachial artery access or some sort of arm access, can be axillary. You may need a pretty large sheath to place a covered stent. I have to admit, I've never done this without a covered stent, but there are some series where they report using an uncovered stent. You place your chimney graft undeployed at the origin of the LSA prior to deploying the aortic stent graft. Then you deploy your main body graft and then rapidly deploy the chimney graft because you already have your wire in the ascending. And again, just a minimum, you want a minimal overlap, at least 1 centimeter to 2 centimeters, and then you want 1 centimeter to protrude proximally. Results are pretty good. Technical success is high. There's a non-trivial number of type 1 or gutter leaks, but these often resolve on their own. Side branch occlusion rates were quite low. One study did make note of the fact that the majority of their endoleaks occurred when the target lesion was on the outer curve rather than the inner curve, so maybe a time to avoid chimney approaches. Periscope sandwich, when you Google it, this is the first picture that comes up, which is adorable. So the definition of a periscope sandwich other than this is a technique incorporating periscope branch vessel stents that are placed between main aortic stent grafts. It's recommended, but not required. They have a through and through wire from a brachial femoral access. If you're going to perform angioplasty, a molding balloon should be placed in the aortic graft, a standard balloon in the branch graft, and this should be done with a kissing technique. Speaking of techniques, you place your first TVAR to be deployed with the proximal end just distal to the left subclavian artery, so in the zone 3 area. Then you establish your wire either through and through or at least down the descending and through your, so from the arm through your first deployed TVAR. You place a long sheath over this into the descending via that TVAR. You then, with that sheath in place, deploy another TVAR that covers the left subclavian origin, but lands short of the common carotid. And then through your brachial sheath, you place your self-expanded stent graft spanning at least 1 centimeter below the distal end of that more proximal TVAR. And at least 2 centimeters into the left subclavian artery. Some people choose to reinforce that overlap zone with self-expanding uncovered stents. So you can see here a lesion that would definitely involve the subclavian. So you need to cover that. Here, the first TVAR is deployed distal to the left subclavian. Then they get their sheath down into the first TVAR. Then you see the second TVAR deployed more proximally. And then the buildup of the stents out in this sandwiched periscope fashion, and then just a completion angiogram. Technical success is very high. Gutter leaks are quite low, and again, often reporting early resolution. Occluded branch rates were low, and you can choose to place uncovered stents to sort of support. The authors of one of the main studies of this also mentioned sort of things that probably don't need to be said, like they're going to have a lower EBL and a shorter operative time compared to surgical debranching. Back table fenestration. Here, the physician modifies a commercially available endograft to allow flow or even place a branch graft into a supraortic vessel. This seems to me like kind of the building your own, building something in your garage. So I got this. So back table fenestrations, you should be planning these on a 3D software system prior to the operation. You should have this all drawn out. Then you unsheath part of the device. You draw it out again on the device. Then you can either use a knife for a scallop or a cautery for either a scallop or a fenestration. You create them. You typically start this work before they induce general anesthesia, but continue through that time. You do sew markers onto your scallops or fens. This can usually just be the snare cut off of a snare kit. Those are very highly visible. Planning for your scallop, the length of this from the leading edge of the graft should be the distance from the distal edge of the left common carotid to the distal edge of the left subclavian. The diameter of your scallop, because you usually don't place a branch graft through here, should be the diameter of the left subclavian plus 5 millimeters. Fenestrations are typically made with cautery again between struts. They should be 2 millimeters smaller than the diameter of the covered stent to help with the seal. Technical success is quite high, but again, these are usually done at centers that are doing this a lot. So the learning curve is not usually in these series. Back table preparation time is short. 1A and 2 endoleaks are low. Here you can see this fenestration is marked with a snare sewn on, and also gives some directionality here with this piece. They also kept the tip captured in this 5 millimeter syringe, which is very helpful for resheathing. I'm not sure what the shoelace here is, but then to resheath it, After they've created their fenestration, they use vessel loops to reload it into the sheath. I've also used umbilical tapes for this, but something needs to be used to get it reconstrained to go back into the sheath. Here is sort of the operative plan. You line your fenestrated graft marker up with your left subclavian, partially deploy your graft, cannulate your into the ascending via your fenestration. When you've confirmed that, you deploy the rest of your graft, deploy your stent, your branch stent, and then remove your wires. And you're done. So lots of types of in situ fenestration. I chose to talk about laser fenestration. There's radiofrequency, there's needle. There are over-the-wire laser systems that connect to a generator. A few are listed here. It is hugely helpful to have a steerable sheath. A Dacron-based graft should be used for the lasering portion of Valiant or TX2. You can use anything distal to that. You need at least 5 millimeters between the leading edge of your graft and your left subclavian to do an in situ fenestration. It is super critical to understand the angle of the left subclavian takeoff in order to make your fenestration. You really want your laser fiber at near 90 degrees to the endograft for a clean circular fenestration. So you can, this is why it's really great to have a steerable sheath. You can see this, and A here is really not going to work out. You're not going to get a good circular fenestration. It may get into your leading edge. B is also got similar problems, but not with the leading edge. C and D are going to work out phenomenally. So you really want to have your brachial sheath and laser fiber positioned at the left subclavian origin before you deploy your stent graft. Then you deploy it and you advance your laser fiber until you can feel the graft. And then you usually need about 3 to 5 seconds of power to create your fenestration. Then it's an over-the-wire system, so you can advance your 018 wire through the catheter and the fenestration, and then switch it out for a stiffer 035, and then predilate your fenestration. Place your branch endograft, or your branch covered stent, and then make sure some of your stent deploys in the lumen and flare that portion. Technical success rate usually has to do with the creation of the fenestration and that angle that we talked about. 79 to 100%. Type 2 endo leaks are pretty low. Branch stent patency was 100%. An important note made in one study I reviewed talked about when your fenestration ends up across some struts, you have a non-trivial chance of bursting your balloon when you go to inflate. And so you really have to be sort of carotid stent style de-airing your endoflator. There are off-the-shelf grafts available as well. There's the Gore thoracic branch graft or single side branch. The Medtronic made a similar thoracic branch graft, and then there's this Castor stent out of China that I have never seen before. So the Gore device is currently available. It's bimodular. There's a main aortic component graft with a portal in it. The side branch is divided into 3 sections. The trailing edge is designed to seal in this portal. It also has a couple of anchors to keep it from sliding. The distal extent of the graft seals in your left subclavian is designed for that. And then there's this intermediary portion that allows flexibility to make these various transitions. You need brachial and femoral access. You ultimately need through and through brachial to femoral access, but the timing of that is a little bit variable. The aortic component, we used to introduce this over both wires and then track it up and then deal for like what felt like months with wire wrap. Now you can actually feed both, feed it over the aortic wire and feed a wire through the branch cannulation site, and then snare that in the descending aorta, and that really decreases wire wrap. And so we've been starting to do it that way a little more frequently. So the process for this graft, obviously, you choose all your components in advance, and then you establish your arch access from the femoral, and at some point you get brachial femoral access. You deliver the main device with the arm sheath and dilator already at the origin of the left subclavian. Then you bring your side branch in through the femoral access, and it helps to kind of wet it to that arm sheath to help it travel through the portal, because that can be a little bit harder than hope. Then you deploy that. This is now FDA approved for zone 2. They're still working on 1, but 2 is approved. Their early feasibility results had 100% technical success. There was no death, stroke, or arm ischemia. They had a fair number of endoleaks, more than a quarter of the patients, but a lot had early resolution as well. Medtronic made another bimodular device. They cleverly called it the Medtronic Mona LSA trial. The main graft goes through femoral access. Their branch goes through the brachial access in this case, again with a through and through wire. They had a feasibility trial that's been presented. They had 100% technical success. They interestingly reported no completion leaks, but half of the patients had leaks develop prior to discharge, which sounds like maybe we just didn't see the leak on the completion, but found it on a CT, I guess. There were no deaths, arm ischemia, conversion, or secondary procedures. There were some strokes, but they reported no major strokes. Unfortunately, the Navions are currently recalled due to stent fractures and type 3 leaks with stent ring enlargement. So none of these are currently available to the best of my knowledge. This caster stent branch graft I have never used or seen. It's made in China. It is, I just bring it up because it's one device consisting of a main graft and a side branch all attached. It is delivered through a single sheath. It's packaged in 2 sections that can be deployed consecutively. They have one year follow-up, which showed no leaks or major morbidity or mortality, but they had a very high immediate or very early stenosis of the side graft. Custom pre-order, there's a stent graft system out of Japan that makes a specific graft for left subclavian flow. These are produced on a per patient basis from 3D models made from preoperative CTAs using specific software. They are an all-in-one graft composed of an aortic trunk section and a branch section, which are sewn together. The main body and the branch are constructed separately from series, 2 separate series of Dacron grafts where they transition in 2 millimeter increments between diameters. And then they sew them all together in whatever the required combination are. These are made of woven polyester and these flexible titanium rings. They have small Dacron cups at the proximal and distal graft edges to ensure tight sealing between the graft and the aortic wall. They look kind of cool. The single branch version has some requirements for the landing zone. It goes through a 22 French. It is released from the sheath in the descending thoracic, but is still constrained by a wire. So then it's advanced as a constrained device into the arch. There's a wire that you snare from left brachial access that comes off the left subclavian branch. When this wire is brought out the arm sheath, then your graft is fixed into place and aligned, so you can deploy it by removing the constraining wire. They just did this under rapid ventricular pacing. They had 100% technical success, but did have a nearly 8% stroke risk. I have not, in full disclosure, ever used this graft, but I would certainly love to. And that's it. I guess we're going to actually wait for questions till the end, so I retract this slide.
Thank you very much, Dr. Bennett, for the great presentation. Very comprehensive, lots to talk about. We're going to move forward with our second talk, and I have the pleasure to introduce Dr. Will Yoon, who is now joining Case Western University Hospitals as an associate professor and associate director of the Aortic Center. He has completed his training for vascular surgery at Loyola in Chicago, and he is now actually finishing his PhD time at the University of Uppsala in Sweden, and he's going to talk to us about strategies for extra anatomic arch debranching in aortic arch pathology. So, Will, go ahead.
Thank you for the kind introduction. Also, thank you very much for this opportunity to present here today. This is a great honor, and also I feel a great pleasure in speaking with great moderators here and the other speakers. So the topic that I have today is strategies for extra anatomic arch debranching and the treatment of aortic arch disease. So this is my disclosure. So the application of TEVAR requires a healthy approximate landing zone, length of at least 2 centimeters for most thoracic endografts that's available today. Due to the anatomic constraints associated with arch angulation and associated supraaortic branches, the patient who presents with thoracic aortic pathologies that extends into the arch are left with no adequate proximal landing zones. And to achieve sufficient proximal landing zones, of course, we need to manage the supraortic branches. As was presented just before, there are a lot of endovascular solutions for these using fenestrated as well as branch devices. But for this topic, we'll discuss traditional surgical extraanatomic debranching for the arch pathologies. The reason why this is quite important is because we have seen that when we don't honor proximal or healthy proximal landing zones, the complication associated with this is quite high. Now, we saw the single side branch before, but an early report from the LA group at USC have shown that for the aortic aneurysms as well as dissections, only 28% of the patients met strict IFU criteria. And we have also looked at this in the patients with blunt traumatic thoracic aortic injuries, and about 32% have met IFU criteria. So clearly, there is still a role for surgical debranching of the aortic arch. Each model classification is quite useful. Of course, we know this classification quite well, and the patients with arch disease that extends proximally, which dictates the length of coverage that's required, hence the need for debranching. So we'll start from zone 2 and move approximately. There is a lot of, there is not a real good consensus in regards to what to do with LSAs, because we do know many patients whose LSA is covered with the thoracic endograft, many of them do quite well. But of course, there's a risk associated with potential arm ischemia, vertebrovascular insufficiencies, spinal cord ischemias, and then in patients with Lima cabbage, of course, then that must be revascularized. So there is SVS recommendations for these, and there's of course a strong recommendation criteria for patients with aforementioned issues. So there are two more common ways to revasculate LSA is, of course, carotid subclavian bypass, and the other one is subclavian carotid transposition. Now, the transposition, of course, does not require any prosthetic graft materials. However, this requires more extensive dissections to gain proximal control and mobilize sufficient length of subclavian artery to allow tension-free anastomosis. But this is, of course, quite difficult when you have a vertebral artery that has very early origin and patient with a Lima bypass. This is a report from the Hamburg group. They have reviewed both carotid subclavian bypass and transpositions, and they have shown that the mortality and morbidity is quite comparable to what is available out in the literature. And they have also shown very good primary patency as well as secondary patency. But what they have noted is that in their experience, transposition had much higher local complication rates, including peripheral nerve injury. So it is their opinion that in their center that perhaps the bypass do better given the lower rates of complications, but the patency were similar. Now, moving on to zone 1, unlike LSA, the coverage of left common carotid artery is not well tolerated, given that this can lead to devastating complications such as stroke. So revascularization of left common carotid is very important. And there are quite two different ways that was described. One most common being carotid crossover bypass, and the other one is axillary artery bypass, which is actually quite widely used in Japan. Now, we do also know from, this is one of the more modern, I suppose, the rates of patency. The carotid crossover bypass also a very acceptable patency rate. This is a group, the Yale group that have looked at NISCUP data, and under their subgroup analysis, that the carotid carotid bypass, and as well as a carotid subclavian bypass, when they're done in combinations, that tends to have higher rates of morbidity, but not necessarily mortality. Now, axillary bypass is a bit of concern because of the length that it requires in subcutaneous tunneling, but in this report, they have shown rather good PNC. And as you can see here, this is another one that was recently published that shows rather good primary and the secondary patency. Now going into zone 0, this is zone 1 surgery that was shown in 2003, which showed combinations of the sequential transpositions to achieve this seal. And since this report, much has been done in terms of zone 0. So total supra-aortic debranching can be performed when ascending aorta to supra-aortic trunk bypasses are done with or without concomitant ascending aortic arch replacement. And these are some of the diagrams, as you can see here. Now, how safe is this? As given this requires sternotomy and bypassing to many of the important vessels, which would increase rate of stroke. But in this review, in their experience, which is from, I believe, 2012, that have actually had a 0% stroke rate, and mortality rate was 9.1%, although they had quite high morbidity. This is most recent publications from here at CASE, and we evaluated 42 patients who had a total debranching without ascending aorta replacement, and one with the replacements, and type 3 being total debranching with ascending aortic and arch reconstruction with elephant trunk. Now you can see here the mortality and paraplegia as well as stroke rate is quite comparable with really good primary patency. So I think the lesson here is if the patients are selected well, then I think zone 0 aortic arch debranching can be done with rather good outcome. I've included this their flow diagram from center in Japan, as well as their surgical plan on the right. Of course, in this case, it's a little bit of an exception because they used axillary bypass instead of carotid subclavian bypass due to their logistic issues with the involvement of neurosurgeons. But I think the point is well taken. I think the message is that the proximal landing zone is quite important and to achieve good outcomes. And when done well, the outcomes are pretty good and safe. You can see here. Their mortality, 30-day mortality rate was 0.6% and stroke rate of 1.1%. But I think the lesson is this is a high volume center, and I think once patient selection is very important, and the volume also decrease rates of complications. So that is it. Thank you very much for your kind attention.
Well, that was a great talk. Absolutely fantastic review. Looking forward to discussing that one once we get to the end of the talks here. Thank you for doing that. It's my pleasure to introduce next Dr. Luis Sanchez, who requires really no introduction to anybody here in the Midwest. Certainly internationally known surgeon. He's the section chief of vascular surgery at Washington University in St. Louis and the co-director of the Barnes Jewish Heart and Vascular Center. Again, internationally known person, the Gregorio Sicard Distinguished Professor of Surgery there, and he'll be talking about the endovascular horizon for the aortic arch. Luis, thanks for joining us and looking forward to your talk.
Thanks, Peter. Thanks again for the invitation. Really a pleasure to participate in these webinars and obviously getting some of this information out there of where we're going with endovascular management of aortic disease, in particular, sort of the next step, which is the aortic arch, is one of the most interesting topics nowadays, and it's continuing to move forward, as you've heard on the prior presentations. All right. There we go. These are my disclosures. I work with many other companies to both evaluate and consider options for the development of new endovascular devices. So as we're talking about the aortic arch, obviously the treatment of choice for the management of complex pathology of the aortic arch in good risk patients is an open total arch replacement. This was initially performed by Dr. Greep in 1975. And as I mentioned, it's still considered the gold standard for the management of these patients if they happen to be good candidates. Obviously, endovascular repair is starting to gain more and more interest for the management of a variety of these patients. The procedures as far as open total arch replacement have become safer with the refinements of better cerebral perfusion and cerebral protection. And there are a variety of techniques that have been used to be able to improve those results, including deep hypothermic arrest, retrograde cerebral perfusion, and selective antegrade perfusion in a variety of these patients. There are multiple techniques that are utilized, and it really depends on the expertise of the surgeon that's doing it, including, an en-bloc reconstruction, the use of elephant trunks, and a variety of techniques to be bifurcated or trifurcated techniques to reperfuse the cerebrovascular circulation. The results have significantly improved over the last few years, with decreasing mortality and stroke down to the single digits. But clearly, this is not applicable to all the patients, and we're treating more and more patients that are older with multiple surgical comorbidities and prior surgeries, that really the consideration of endovascular repair is there to try to diminish the morbidity and mortality associated with a new reconstruction. And that is much higher with a redo, second or third time, opening of the median, doing a median sternotomy and being able to reconstruct the arch. Elephant trunks have been used as one of the ways to be able to create a good landing zone for endovascular repair in the past, and have been tremendously useful for the management of patients with aneurysms and dissections. There are multiple techniques that have been used. In particular, I wanted to mention the frozen elephant trunk technique, that it's grown in interest on patients that are good candidates for treatment of the aortic arch using open repair. And now with the Thoraflex device that was approved in the United States over the last year, we can have a good elephant trunk with an associated end that's an endograft for attachment of further thoracic endografts and reconstruction of the remaining aorta, if necessary, depending on the patient's pathology, be extensive aneurysms or those patients that have thoracoabdominal dissections that need further treatment below the aortic arch. Hybrid techniques have been used in the past, as mentioned before by William, in particular in patients that are considered to be high risk. They're clearly less invasive. They're technically a little bit easier than having to do a full open arch repair. But there are no randomized trials related to many of these techniques. There's a lot of series that show that the results are quite reasonable in well-selected patients that can be managed in this fashion, especially patients that have had prior surgery. The branching procedures vary, as it was mentioned in the prior presentation, depending on the aortic zone that's being treated, but there are opportunities and ways to be able to fully debranch the aortic arch branches with good long-term results in expert hands. If you compare the management of the aortic arch with total open repair versus hybrid techniques, the results are quite comparable in a number of these series that have been published since 2013 to 2016 in centers that do both procedures. Keep in mind that the vast majority of the patients that underwent hybrid techniques are those that were considered to be higher risk to be able to have a standard total open arch repair. Well, where are we going really with the endovascular management of this area now and in the future? And you heard a little bit already from the first presentation of some of the devices that are already in the market in the US. The Gore thoracic branch device was approved recently this year, and it's already being used more and more for the management of aortic arch pathology with a single branch. It's mainly used for the subclavian artery. The data that's currently available and led to its approval was related to the subclavian artery. They're still collecting more data regarding the other branches, but the device is fully approved for utilization in the US, even though people are being trained in a safe and effective fashion so that they gain experience with the device. The terumoral relay branch device is, as well as the Cook 8-branch device and Nexus and Span device, are devices that are being used under IDEs or under trials in the US with double or single branches, and I'll talk a little more about them. The ascending aortic grafts are being developed and evaluated in the US, especially the Gore ascending graft. And there's an interesting dissection stent that is under evaluation for the aortic arch, which may help us manage especially patients with thoracic dissections. Talking about the Gore thoracic branch device, you heard a little bit about it already. It's really the first FDA-approved device with branches in the aortic arch. It can manage patients with zone 0 to zone 2. It's currently, the data that's available is for zone 2, even though the device is really manufactured to accommodate even larger branches as a single branch with associated reconstructions extra-anatomically. The patency rate at 12 months for that device was excellent in the trial at over 99%, and had a relatively low stroke rate of around 3.4%, mostly associated with the manipulations that have to occur inside the aortic arch, which is what leads in many of these devices to the slightly higher risk of stroke, especially in patients with very diseased aortic arches. If you look at some of the other devices that are currently in trials, the Terumo relay branch device has been in trials in the United States for approximately 3 to 4 years. Obviously, everything slowed down with the COVID years. It's completing or has completed recently a feasibility trial with reasonable results. The early experience had a moderate stroke rate due to the manipulations of multiple branches, something that has significantly improved with changing the sequence of the steps of the procedure. Some of the data that's available from experience in Europe mainly, and in Japan is the other site that has significant experience with this device, with their initial 43 patients that had an in-hospital mortality of 9%. Interestingly, that occurred only on patients with aneurysms. Patients with dissections had a lower mortality rate. Their stroke rate was around 7%, also higher in patients with aneurysms, lower for patients that have dissections, relatively low major endoleaks, 1A or 1B, and only a 3% aortic-related late mortality, all of which was associated with residual dissections in patients with very complex aortic anatomy. If we look at the Cook 8-branch device, is only available in the US under IDE trials, as it's not a full open trial in the US. They have a 2-branch or a 3-branch configuration, and it's custom made to the patient at this point. In this experience from the IDE data of 70 patients, they had a low perioperative mortality rate of around 2.9%, a low stroke rate of less than 3%, no spinal cord ischemia, low complication rates. But as you can see, the early and late reinterventions in this particular group was relatively high, as we're learning more and more the management and what are the situations that we encounter in the aortic arch with such mobility of these branches and the aortic arch and the ascending aorta itself. The Nexus and Span is on trials in the US currently with a feasibility trial ongoing. This is a different device with sort of a different construction and mechanism of deployment. It's a single branch device, which is made to go into the brachiocephalic or innominate artery with a through-and-through wire from the right arm to the femoral access. The main component is deployed first, and as a secondary step, the ascending component is bridged into the ascending aorta, joining the main component of the device, requiring complete cervical debranching to be able to maintain perfusion to all branches above. In this early series from Europe with a single branch device, they had 100% procedural success rate. The majority of the patients had isolated arch aneurysms, but in the current feasibility trial, aneurysms and dissections are accepted in the US. They had a 7.1% 30-day mortality and a relatively low stroke rate at 3.6%, which is very comparable to the stroke rate of many other series treating arch devices. Here we go. So the Gore ascending aortic graft is one that has been in feasibility trials in the US, initially evaluated for the management of patients that have type A dissections, but it can be used for other pathologies that start or are limited to the ascending aorta. The ARISE 1 feasibility trial was completed with reasonably good results, and currently the pivotal trial is under organization. The devices are 34 to 53 millimeters in diameter, and they come in different lengths, 7, 8, and 10 centimeters, to try to better accommodate the ascending aorta, which is one of the most difficult places to accommodate accurately a endovascular graft. Some of the anatomical challenges that occur at the ascending aorta is the different alignment that occurs between the lesser and greater curvature of the ascending aorta, with the lesser curvature often being a lot shorter than the greater curvature. You want to make sure that you have seal proximally and distally to the area that you're trying to treat to obtain the best possible result. And with all these devices, the nose cone needs to be advanced often across the aortic valve. So some patients that have prosthetic aortic valves may not be candidates to be able to use really any of these arch devices that require advancement of the device further to be able to have appropriate deployment. The ARISE 2 pivotal trial is intended to be able to treat and evaluate the management of pseudoaneurysms, type A dissections, and a variety of other isolated lesions that may benefit from treatment from endovascular grafts. And these are just some examples of those patients with pseudoaneurysms of the ascending aorta or other complex lesions that have been treated under sort of custom design initially to see how the device behaves in this challenging situations. And lastly, there's a dissection stent that is being evaluated for the management in the aortic arch, something that can be combined with your standard management of the ascending aorta in an open fashion and try to complement the ascending aortic surgical reconstruction with an open stent that would be placed in the true lumen of a extensive dissection, hopefully opening the true lumen, sealing the false lumen as best as possible, so that there's the opportunity of the dissection healing fully and trying to avoid any further need for other interventions. In the early German experience, with 46 patients, majority of the patients had a hemiarch. They had a 30-day mortality of 13% with a 1-year mortality of around 19%. Keep in mind that all these patients are having emergency ascending aortic repair to start with. 6.5% stroke rate, no paraplegia, and at least on their follow-up, which is still relatively short, they did not have issues with stent fractures, aortic injury, or other problems. Reintervention rates, obviously, like most of the patients that have an extensive dissection, continues to be an issue, but with this stent, it may decrease the need for further reinterventions if it works as planned, but we still need a lot more data to be able to understand its application. So in conclusion, open repair of the aortic arch pathologies continues to be the gold standard for good risk patients with suitable anatomy, cared by experienced surgeons and centers of excellence that have a lot of experience. Endovascular techniques continue to improve and are an excellent option for high-risk patients, not candidates for traditional open repair. And further device improvement are still necessary to better accommodate the dynamic and challenging aortic arch anatomy with good, short and long-term results. Thank you very much.
Thank you very much, Dr. Sanchez, for this excellent talk. Finally, last but not least, I'm going to introduce Dr. Christine Orion, who is an associate professor of surgery at The Ohio State University, completed her vascular training at the Johns Hopkins University. And she's going to talk to us about multidisciplinary collaboration in the treatment of complex aortic arch disease. Christine.
Thank you so much for having me. Thanks to Midwestern. I really enjoy participating in this webinar series. I think it's a nice hour of time, a lot of information. So again, I'm Christine Orion, one of the vascular surgeons at Ohio State. I'm going to be talking about multidisciplinary collaboration in the treatment of complex aortic arch disease. I have no disclosures. So for many decades in medicine, a multidisciplinary team approach has really been proven to have improved patient outcomes. This is all different areas, from diabetic foot wounds to cancer to transplants, for the last 40 or 50 years. And so it's not much of a jump to think that multidisciplinary effort in patients undergoing complex aortic surgery would have improved outcomes. And this is sort of the approach that we take here at Ohio State. We have a really excellent relationship with our cardiac surgeons. And so I wanted to just take the next 9 minutes or so to talk to you a little bit about how we got there and maybe give you some advice perhaps about how you can improve your collaboration with your cardiac surgery colleagues. So Drs. Sanchez, Yoon, and Bennett have already done a fantastic job talking about all the technical aspects of what we can do in the aortic arch: endovascular, open, hybrid, lots of different tools in our tool belt. Really the pinnacle of vascular surgery and cardiac surgery coming together. But I'll tell you that collaboration between the two teams, it doesn't start in the arch. This is kind of where you want to end up. And so I'm going to take you through a couple of cases about how you can build your relationship so that you can get to this point. So, you know, the low-lying fruit to build your relationship are sort of the oldies but goodies. I'm not obviously going to press my practice on anybody here on the call. Everybody has their own ways of practicing, but certainly I do offer some cases. I offer a simultaneous carotid and CABG. For instance, this is a very young lady, 56-year-old woman who had symptomatic coronary artery disease needing a 3-vessel CABG, was found to have high-grade right carotid stenosis that you see here on the CAT scan. We verified it with our ultrasound in the vascular lab. Peak systolic of almost 400 and end diastolic of greater than 150. So in this patient, you know, I offer a simultaneous carotid and CABG. And so, you know, I often go first. The cardiac surgeons will position, and you have to be a little bit flexible. It might not be the exact position that you like to have for your carotid, but, you know, we're savvy, we're flexible. So they position, I go first. I do this under shunt, it doesn't take very long. I reverse my very small dose of heparin, and then I sort of leave a lap pad in the neck. I let them do their thing. And then once they're done, I come back and sort of close the skin. It's a little bit anxiety provoking, I will admit. We want to know that the patients are going to move everything and, you know, that they wake up without a stroke. And so the finger pointing doesn't start. But I'll tell you that sometimes this is a nice opportunity to sort of collaborate with your cardiac surgeons. So oncology cases, these are great cases to collaborate. So this was a 72-year-old woman that was recently diagnosed with renal cell carcinoma with level 4 thrombus. So you can see in the coronal views there, pretty much her cava is totally obliterated with thrombus and cancer, sort of peeking up above the diaphragm there on the axial view. And so for this, we collaborated with urology and cardiac surgery. So we thought we needed intrathoracic control of the cava and with the bailout of cardiopulmonary bypass in the event that we struggled getting this tumor out. So cardiac surgery came in, they did their nice sternotomy. It's a very skinny patient. We did sort of a retroperitoneal incision on the right side. We're able to put a clamp above the diaphragm and then kind of toothpaste out the thrombus and then replace the clamp. And so avoided cardiopulmonary bypass. But these are great cases. Vascular surgeons love these cases. It's sort of low risk for the cardiac surgeons, right? So it's easy sternotomy. They just have to put somebody on bypass. They usually have a pretty good heart to begin with. So they sort of have minimal risk and they enjoy it. So this is a nice opportunity to kind of bring your cardiac surgeons to the table. So not always are we coming running for TAVRs for, you know, iliacs on a stick and whatnot. We're often consulted ahead of time in complex patients that have difficult access. And so this is a 70-year-old patient who actually had bilateral fempops in the past, both occluded, of course, who came in with a severe aortic stenosis needing a TAVR. During her workup, she was actually found to have rest pain on the left with a little tiny dot of gangrene on her hallux and horrible access. So you can see here, her left subclavian's totally out, her right iliac's totally out, both femoral arteries totally out, and her axillary artery measured about 3 millimeters. So for this patient, I actually went and did a left iliofemoral interposition graft to the profunda. And then I went through that graft and gave them their nice sheath. There was this huge plaque sort of infrarenally here. So I didn't, you know, got them across that plaque, gave them their sheath. They TAVR'd, that went great. And then on the way out, I did a fem above knee bypass with plastic because interestingly enough, she had 3-vessel runoff below her knee and she did great. So once, you know, you get through some of these lower lying fruit, you start to get a little bit more complex cases. So dissections, we collaborate frequently on the malperfused patients that come in. And so for such patients like this, so obviously type A dissection comes all the way down. You can see that the left iliac comes out, and this patient had profound leg ischemia when they came in. And so depending on how long it's going to take them to reperfuse that true lumen, you know, I'll often come into the operating room and we'll kind of share real estate, and I'll do a quick fem bypass, 60 minutes, 2 little small incisions. Maybe I get a little bit of blood flow, you know, even a few hours before they're going to reestablish blood flow down that true lumen, and perhaps we can salvage a leg. Now, take this with a grain of salt, because once they reperfuse that true lumen, your fem may go down for competitive flow, but that's okay if the patient's got blood flow to her legs. Unfortunately, you know, SMA, bowel ischemia patients, these are very complex patients. They come in with a type A dissection, they've got peritonitis and maybe, you know, bowel necrosis. And so, you know, these are complex patients needing a discussion between you and the cardiac surgeon. And those discussions often go a lot easier if you have a little bit of a relationship before those patients show up at your door. And ultimately, this is what you want to get to, or at least what I want to get to. So open thoric abdominal work, this is my passion. So we do these in a team here at Ohio State. Cardiac gets into the chest, I get out the groin. They put them on left heart bypass or circ arrest, depending on what they need. The cardiac surgeon and their fellow does the proximal. My fellow does all of the distal. It's great. It's a well-oiled machine. It's nice to have an extra attending in there. These can be complex cases in case you have to think on your feet. And really, this is like sort of the pinnacle work of collaboration for me. So once you get to open thoric abdominal work, you're ready. Like now you can start approaching the complex aortic archwork that the other speakers have already spoken about today. So key points to collaboration. I mean, these are obvious, right? But it's a little bit more difficult to practice in real life. So communication's key. You want to talk attending surgeon to attending surgeon. Don't have your people call their people and go up the chain. It just doesn't work like that. So pick up the phone, call them up and say, hey, I have Mr. Smith in clinic. You did a cabbage on them. I'm going to fix their aneurysm. Just start out small like that, just to like get on the phone and start that relationship up. Obviously, you have to have mutual respect. And when I say don't be a stranger. So this is, you know, the Ross Hart Hospital. So it's a very small standalone hospital. We have 7 operating rooms. I often will peek in on their cases. They come into my cases, and it's a really close relationship, and it's nice. But perhaps you don't have a standalone hospital, or maybe you don't already have relationships. So here's a couple of opportunities that I might suggest to you. Monthly conference. So we hold an aortic conference. So we invite cardiac surgery and cardiac anesthesiology. We sort of discuss the complex cases, where we're going to clamp, what kind of bypass they're going to need, and it's nice. Invite them to regional meetings. So we had a recent aortic meeting and vascular ultrasound meeting. So we invited our cardiac surgeons to come in and showcase their work and sort of, you know, get to know our regional colleagues. Pre-op huddles is key, especially for these combined cases, once you start doing them. So I like just 15 minutes ahead of time, call everybody in. I bring my nurses in, the perfusionists, I bring the scrubs in, and, you know, you get to talk about, you know, what the goals of the case are, what they're concerned about on their part, and, you know, try to troubleshoot any milestones that may come up during the case. So if you don't have any of these opportunities, quality improvement projects for sure. Every single institution wants to decrease length of stay, readmissions, and infections. So perhaps you share the same nursing floor, you share the same nurses, or perhaps you share the same advanced practice practitioners. You're going to pick up a quality project. So invite your cardiac surgery colleagues to sort of take part in that, and that can really sort of spark your relationship. So I'll tell you, it's not always them that are calling us for help. I have called them several times. And so in this case, this is a young gentleman who came in with an IMH and just didn't look right. Persistent back pain, kind of sweaty, you know, controlled his blood pressure, but ultimately I offered him a TVAR. So we brought him to the operating room and made a little incision for our TVAR, and just is not doing well, just sort of crumps. So we put down an echo probe, and this is moving a lot more than I expected to move, right? So IMH is moving too much more. We're looking around more, and now we see pericardial fluid. So the patient actually had a retrograde dissection on the table. We're in the hybrid room. It's the worst room possible to bring a pump in. But because we have a good relationship, I called up my cardiac colleagues. They came in. We did a sternotomy, did a total arch, did a frozen elephant trunk. It was super uncomfortable around the II, but the patient did very well. And so take it from John Lennon. I get by with a little help of my friends. These are big cases, and collaboration is good. And I think that is all I have. Thank you.
Christine, that was a great talk and 4 wonderful talks this evening. Thank you very much for doing that. It's a great insight on collaborative relationships. We're going to open up for questions from all the attendees. You can enter your questions in the Q&A section underneath or in the chat. That we have one question in the Q&A so far, which is directed to Dr. Yoon, but I think it's a good one for the whole group, and I'd like to tack onto this one a little bit. So the question is, should the carotid subclavian bypass be done in a 2-phase operation where the patient comes in and then has a separate operation for their TVAR? So staging the carotid subclavian from a TVAR for a debranching. The other thing I'd like to ask for the people who have been speakers this evening are, for a carotid bypass, what do you use for your conduit and how are you doing your tunneling? It's a good question for all of the trainees on the line.
To answer that question about the timing or 2-phase versus 1 phase, it is my preference to do everything in one setting. I think it just minimizes additional anesthesia. And we all have very tight OR schedule. So my preference is to do everything at once. So this way you don't have to worry about it. And I don't think it adds that much time. I think by separating, you actually spend more time doing these 2 separate cases. So it is my preference to do everything at once.
I would agree with that as well. Sorry that I kind of jumped in, Kyla. You go ahead.
No, I do the same. I do them in one, but I have a lot of partners who do them in 2. But I typically like to just get it done in one. I don't think you're staging out any risk usually. And again, I just have issues getting OR time. So it seems important. And then your other question was about conduit for carotid bypass. I use PTFE ringed usually.
Yeah, I guess I have the tendency of trying to do the procedure at the same time for similar reasons as everybody else. There are particular patients that, because of the complexity of both procedures, you may want to separate them. But if it's a straightforward TVAR and some kind of extra anatomic bypass, have the tendency of just doing them at the same time to diminish the anesthesia time for that patient. And for the same time, we're all needing more OR time everywhere. Really, we need more staff than OR space, but still OR time. As far as the conduit is concerned, I have the preference of also using PTFE, using the smaller ones, maybe 6 and 7s, not larger, especially if you go retropharyngeal. A lot of the patients with the larger grafts have some symptoms, at least short-term, if not long-term, of dysphagia. It's what we've seen. So I try not to put the very large ones in that space. And prefer to put it there as opposed to in the anterior portion of the neck, with always the concern of something will happen to that patient. They need a median sternotomy and no one knows, or other potential issues that may occur to that patient with easier compression of a very anterior graft.
Yeah, I would agree. It's sort of patient dependent. If you can do the TVAR and debranch in one, if it's complex, I will tend to split them up, the next day or 2 days later. I think that's fine. I also use PTFE for the carotid. Actually, my partner just published a case on this, that we use the pre-made Axe Bifem graft, and we use that for the carotid. Actually went great. It actually fit really nicely. That was an 8 millimeter actually. We went retropharyngeal. So
we have a few questions that are coming through from the attendees. We'll go in order here. This is kind of an open question that we can chat a little bit about it. Where do you think the arch will be in the next 5 years with all these new endovascular approaches? Will it be a main vascular area versus cardiac, or a combination? Obviously, we're all going to say that it's going to be at least a combination or main vascular, but definitely not a main cardiac area, right?
I guess go ahead, Will.
Oh, no, please. I just wanted to echo what Bernardo just said. I think it'll be mainly vascular. Of course, having a great relationship with cardiac surgeons is very important to have a good outcome.
Yeah, I agree with that. I think, just like Christine mentioned, the need to having that relationship in your institution is going to be really important for both practices to flourish as you're trying to figure out some of these really complex arch patients. that we'll see. Many of them have had prior surgery, prior ascendings, all sorts of other combinations. But clearly endovascular repair will have a continued increasing role to the management of these patients. Maybe we'll leave the sort of connective tissue patients still on the side and still have open surgery, especially if they're nice and young and it's the first time they get a sternotomy, maybe at least a second one. But we're seeing a lot of people come back after 2 sternotomies, and the first thing they say is, you are not splitting my chest again. You need to figure out some other way of having some type of reconstruction. So I think that the role will increase. I think the biggest issue is going to be stroke. If we cannot control the stroke rate around the treatment in the arch, still, then there's going to be a very slow process to advance the endovascular side. I think we're getting better and better, and it's not quite comparable, but getting there when you're taking into account you're treating higher risk patients. But that's going to be, I think, the most important part.
And also a challenge, considering that if we have 1 stroke in your first 10 endo-arch cases, that's a 10%, which is basically what the series of frozen elephant trunk, and total arch open repair have. So then you have to maintain that standard very well once you complete 20, 30, 50, 100 cases. So I agree with that. I think there is a new breed that is growing quite fast, which are the surgeons that are vascular surgeons that go on to have a cardiovascular training subsequently. Perhaps those ultra specialized surgeons will be the leading ones in the aortic arch. I know a good handful of colleagues that did their vascular residency and are going for a cardiac fellowship subsequently.
Yeah, that kind of goes along here with the question that Jeff Jim actually put in here, that a lot of our vascular colleagues are working without cardiac surgeons. Is it okay to start tackling the arch without them? And, I think that what you just said, Bernardo, is a very important point. It doesn't take very many problems in your first 10 to potentially even terminate your career. Right. I think if you're going to take this stuff on, you better have good backup, because if you have a retrograde type A in one of your first 5 arches and somebody gets hold of that's not going to go well. You need to have a really good collaborative relationship to make that work. I'm kind of interested in what you guys all think of that.
Yeah. No, I think that's going to be critically important. And the location that you pick, you need to have that backup, very much like everybody likes to have a vascular surgeon around. All the other surgeons in the hospital like to have a vascular surgeon around just in case they get in trouble. This is an area that clearly we have to work collaboratively, at least plan things appropriately, and continue to help each other to be able to move the endovascular treatment in the aortic arch much, much further. And everybody in the institution has to have buy-in that this is a good thing for the patients, which I think ultimately, we all think so, with the less invasive nature and the ability to have reasonable short-term and hopefully long-term results with some of these devices.
Yeah, and if you haven't had a retrograde type A, you simply haven't done enough T-bars.
Yeah,
that it really is that simple. And it's you better have that relationship there. And it's sort of like a cardiologist trying to do outpatient PCI with no cardiac surgeons around. Only bad things can happen.
Yeah.
Next question here. For the Gore tech device, I think they mean the TBE device. Is radial access an option as opposed to brachial? Perhaps Kyla, I think this was more in the realm of your talk. Do you want to tackle that one?
Yeah, I have never done that personally. You don't need a very big sheath in the radial access, in the brachial access. So I guess it's feasible. Certainly you need longer equipment. And again, part of the issue is manipulating, part of what that sheath helps with is manipulating the stent around that portal and up into, especially with the different angulations you can get with the subclavian takeoff. I think it may make some of that assistance from the brachial approach a little bit less present. I think there'll be some issues with manipulability from that, which may or may not be a word, but with the ability to really move things around from that access. I think you'd lose something doing that, but I'm certainly not going to say it can't be done. I'm sure there's somebody who can do that.
Yeah, I think that with the sort of newer equipment that is being developed, smaller sheaths, that work pretty well now from the radial access, that has been used really for all sorts of other cardiac and other interventions. I think it works pretty well. The last few we've done since approval, we've done them from the radial artery with a long 5' sheath. And as you said, it's really important that that sheath goes through the portal to guide you and get that branch into good position. But at least up to now, in the first few, it has worked well. But you need to have a sheath of the appropriate length so you can get down through that portal and be able to match your branch device and get it into place. But it is clearly a possibility.
No,
And I
that's how
think I'm and not advocating for this will be off-label, but I think from a feasibility standpoint, I also think that ultimately, depending on the anatomy and as the experience with the TBE mounts, now that it has been approved, I think it would also be possible to perform the case totally percutaneous from the groin, because you can access you can definitely access the portal when you can advance your large sheath with the side stent without having through and through access. You just need to be careful with the way that sheath can catch on that portal, but I think it will also be feasible from that standpoint.
Yeah, I mean, we just need to learn, get some experience using the device and see how much we can do safely with it. But even
definitely, I'm not advocating for that right now.
That's right. No, it's as we get better and better, those are the things we're going to do.
And Christine had actually put a question in here, which is an interesting one. Any experience with endovascular treatment for pseudoaneurysm in the ascending with cuffs? And we've done a couple actually transapical on patients that have had really, really poor access with the pseudoaneurysm after a previous right hemiarch. Do a mini thoracotomy, do a transapical approach and put those in. It's always interesting. Obviously they do TAVRs that way. Sticking a big sheet through the valve is obviously not that big of a deal. What do you guys think about the cuffs and the ascending for small pseudoaneurysm, particularly an anastomotic?
I think especially, as you said, an anastomotic or from other access that has been obtained in people that had a cabbage, et cetera, have a pseudoaneurysm with a relatively small hole. People have used some of the plugs in that site, but they haven't worked particularly well, at least in our experience. Having something covered in the arch will ultimately be best. Cuffs of the appropriate size, if the patient has a good ascending, will probably work. We've used some of the shorter devices a few times on patients that have had a long ascending and can fit one of the shorter devices. They've worked okay, but obviously they're not made for the ascending. It'll be nice to have a device that accommodates that lesser curvature better. But those are the patients that are redos and looking for an endovascular option. Even transapical is a very potential option in that group.
We've done a few of those in that similar setting. Mostly there were patients that were completely turned off by cardiac surgery as a third or fourth time reduced sternotomy with a pseudoaneurysm between an ascending graft and the total arch graft, complete separation. And the good thing is that those patients tend to have an elongation of their graft, which sometimes is redundant. Either is redundant or is kinked. That's what we usually see. And the redundant ones, you might even have 10 centimeters on the outer curvature, which will be enough for an actual stent graft. The problem with the cuff is that usually the delivery system of the cuff doesn't reach the ascending because it's developed to be an infrarenal cuff, right? So we have done a few TVARs for that. We had an experience with the ascend graft from Cook, which is basically an ascending graft with a longer delivery system, shorter nose cone. It works, in the right patient, it works. I think the Arise trial from Gore and the ascending device from Gore, I think it will have great applicability for these pseudoaneurysms, these patients, and perhaps for some type A aortic dissections, which is really, I think that's really one of the pinnacles, really, to use one of the words that you used, Christine. One of the pinnacles really for ascending treatment will be the type A aortic dissections, but most of them are very low. They are right at the sinotubular junction, so the anatomy there is going to be a little complicated. But I think it's feasible, and I think he needs to be in your radar for those cases, in my opinion.
And if you drop an actual 10 centimeter TVAR, which will be the only thing with length for these ascending pseudos or whatever, do they all have AC locators on the coronary buttons, or how are you identifying the core origins and not covering them? So it seems like a quick case if you do that.
That's a great question. I think it depends a lot on the anatomy of the patient. You don't have that much precision to deploy that graft down up there, you know, because you have all that curvature idea. The case that I did, the latest, I used the 65 centimeter sheath to be able to get all the way there and have as close of a control as I could. And I had a decent landing zone, so I just did an angiogram with my catheter really close to the valve, so I could see the coronaries very well. But in the past, for some arch cases, when we had the arch devices through the IDE here, when the proximal landing zone was very short, we put the guide into the coronary artery, the highest coronary artery coming from the radial, which really didn't affect our axis that much. And that gave us a very nice kind of precise area to deploy the graft. I guess maybe Luis can give an impression on that because he has done a number of the relay grafts too. But I think that, you know, putting a guide on the coronary, we obviously had a cardiologist in to help us with that. I think it helps quite a bit because then you have a very clear notion of where that is. I have even seen people putting a coronary stent at the origin of the vessel, but not deploy, so that if you end up covering, the patient has an ST elevation at that time, then you go ahead and deploy and almost like a chimney of the coronary, but that, you know, then your coronary starts to spasm during that. So I don't know if I like that idea.
Yeah, I think you need a guiding catheter, also overdrive pacing, the same as they do with TAVR. But I'm not sure what you think about that one, but I definitely overdrive pace all those when they're done, if you're in the ascending. And my end is low on those, but certainly we've done it.
Yeah, I think that's the most critical part, especially for those that you need to see the highest coronary really well when you're getting some of these full arch devices that you want to go well into the ascending to be able to get a seal. And that rapid pacing is critical, that the timing is perfect so that you can get that device very accurately and fully deployed in a short time without going too far forward. Because the worst part is trying to deploy one of those devices, and then if you go too forward, obviously the coronaries are there, but if you're too far back and you don't get a seal, you don't have a good landing zone, now you have very little room to put a cuff or do anything else from an endovascular fashion. So accuracy is critical.
Yeah, it's we're at about 7:13 now. It's probably about time to wrap it up. I mean, this has been an awesome conversation, and 4 really, really awesome talks tonight. I'd really like to thank all the panelists, Bernardo, my co-host, for this. I mean, it's really been just a fantastic evening. Certainly, all of our contact information is available to everybody on the Midwest Vascular website and the New Horizons Committee. Thank you for doing all the organization for this. I don't have a whole lot of other wrap-up thoughts for this one, but I think it is probably time for us to let our attendees on their way for the evening. Thank you guys very much for all your hard work on getting these talks ready.
Thank you very much. It was a
Thank you
great
very much,
group.
everyone.
Thank you.
Take care, everybody.
Thank you.
Have a good night.